Good morning. Good morning. Welcome to the Public Safety Committee. This will be Representative Walkie and Randleman's interim study, and I'm going to let Representative Randleman introduce his people, and instead of directing questions to the chair, I'll just let you direct them directly to Randleman. That's okay with everybody? Go ahead, Representative.
Thank you, Mr. Chair. Let me say this. I want to really thank each one of you here this morning for giving attention to this topic. Mental health is one that is real critical in the state of Oklahoma, and for you being here and participating in this, I think it's very important for this state, and this can be a leading into what we want to do. One thing I'll say is that this has two parts. One goal in it is to establish that we need more mental health crisis units to handle the problems that we have out here with children and adolescents. And secondly, helping the police, sheriff, or whoever's attending to that individual, that they recognize whether that's a psychiatric problem or where that is maybe a conduct type disorder, that we should use the jail. So those are the two intentions. I'll turn it over to Representative Walkie. He'll probably say a little bit about that before we get going. He and I have worked on this in the beginning, and I want to appreciate you, Representative, very much. Okay.
Thank you, Representative. Thank you, Mr. Chair, and thank you, members, for being here today, as well as the guests. And I'll echo everything that Representative Randleman said, and I'll just add this. This started as a bipartisan project because I think that we all realize that mental health is not a partisan issue, nor is improving our criminal justice system for those individuals in need of care. And so I think that this is the work of the people, and I appreciate the time that each and every one of you are committing for this program today. With that, I'll turn it back over to you, Mr. Randleman.
Thank you, Representative Walkie. What I'm going to do, there's 5 speakers, so we have 30 minutes each and then 5 minutes of questions. So we're really going to try to stay to that schedule, so I want to get started pretty soon. I will let the speakers introduce themselves. If you look at their history and what they've done, it would take this entire time. I'm really proud of the people that we have here to do this today, but there are 2 of them that need to get out of here pretty soon. The first one, Commissioner of Mental Health, Carrie Slatten Hodges. I'll turn that over to you. I've worked with this lady a number of times on other boards, and she's awesome, and I love what she's doing now. Carrie?
Good morning, and thank you for having me. Did you just want me to introduce myself or go ahead and start? So, yes, I'm Carrie Slatten Hodges, and I have worked in mental health and addiction services pretty much my entire adult career. I started out in rural Oklahoma, out in western Oklahoma. I worked for a mental health center there that covered 8 rural counties and did everything imaginable there up until I became the chief of operations for that agency, which then merged with an urban agency. So I came to the metro area then, which was where I was originally from. I was the chief of operations for Red Rock Behavioral Health for many, many years. After that, I became deputy commissioner at the Department of Mental Health and Substance Abuse Services and served in that role for 12 years and have been in this role since a year ago. Well, it'll be 2 years in February as the commissioner at the Department of Mental Health and Substance Abuse Services. I can say that I think even if I wasn't in this job, this is what I would be doing. For some reason, I've just had a real calling to around mental health and addiction issues and persons in our state who have those issues and how we can have the very best system possible and to be a state ultimately where anybody who needs care at any time can receive that at the level that they need wherever they are at. And that's always been my goal, and it will continue to be my goal. Hopefully we will achieve that in my lifetime.
Yes, go right ahead and start.
So I'm going to give you a little bit of history as we talk about the intersection between mental health and criminal justice, and then I'll talk about some things happening in the future. I'm not sure who's advancing, but
control of this. You do?
I will continue talking as y'all work on that. So the Department of Mental Health and Substance Abuse Services serves a large number of persons across the state, but it is not nearly the number of persons that the data shows us actually have mental health issues. So we serve around 200,000 persons a year, and information shows us that between 750 and 900,000 persons suffer from mental illness in our state. So we know that a large percentage of people either are not realizing that of their own accord, or there's barriers to them receiving care, or they're afraid to reach out for care. And that gap is oftentimes where we are talking about. When people are not receiving care, they're much more likely to intersect with the criminal justice system. So I'll tell you about a little bit about some of the things that we have done and are doing. One is offender screening. I'm not sure if folks realize that we do this, but we started this several years ago. We started it more as a pilot in our state, and then we brought the data back to the legislature about a year after we started the pilot, and now we do this statewide. And that is where any person who comes in contact with the criminal justice system that is charged with a felony that is has an opportunity for diversion, then we do an assessment and screening on that person. We screen for mental health issues, for addiction issues, and criminogenic risk, which tells us whether or not that person is likely to reoffend, how much criminogenic thinking they have going on. And then that places that person into one of four quadrants, basically either has high needs for treatment, low needs for treatment, coupled with either a high criminogenic risk or a low criminogenic risk. And then each time we do one of these screenings, we send a report to the court that lets the court know the outcomes of that screening. And it recommends to them possible diversion opportunities for that person based upon how they screen. Now, the good news is that a lot of people take advantage of that information, and it routes persons towards a diversion opportunity. But not all court systems do. Some lag behind in that, and some, whether it be because they know that person and they're frustrated with the number of times they've touched the criminal justice system, or whether they just have a mindset that they feel differently about how this should be handled. So some places do a great job with diversion, and some places not so much. I think I will have you move forward because I have just a couple of, on our offender screenings, it's available in all 77 counties, and we've screened over 54,000 defendants since August of 2021. So as you can see, we screen a lot of people, and we provide that report then to the court system. And then you can see the outcomes of those screenings. About 18% went on to prison of all of the felonies that we screen, and the majority of those go a different way. Sometimes they're dismissed pending the person get into treatment. Sometimes they go to our specialty court programs. Sometimes they go to community sentencing, and sometimes they go to DA supervision. So we feel like this has been a very successful program, and once they have been charged with the crime, we're able to divert a great number of people through this screening program. One of the things also, I feel like most folks in Oklahoma know about drug courts and mental health courts. I'll give you kind of just a brief overview. Those are two types of criminal diversion courts that are options in our state. When a DA is looking at a case, the DA is the gatekeeper to those courts. And when they're looking at a case, if they feel like the driving factor has to do either with mental illness or addiction issues, they can choose to have that person go the route of a drug court or a mental health court. And those courts then are much more person-centric, And they really focus on the person getting in and staying in treatment over a course of time, and having accountability for their actions, which could mean that they must either volunteer or become employed. If it's a drug court, have regular drug screenings. There's a lot of supervision and oversight that comes with those courts, a lot of accountability. The good news is that those courts are actually less expensive than sending someone to prison, and they have much better outcomes. When we do a cross-sectional data analysis and look at people who went to prison for the exact same charge with the exact same history, they are 25% likely to reoffend and become reincarcerated. If they have gone through one of the diversionary courts, it's less than 7% that person will become involved with the criminal justice system again. So not only is it less expensive, the long-term outcomes are much, much better with going the route of a mental health court or a drug court. But one of the things that has happened as we've gone along is we realize that we are missing a lot of people in our state who have a misdemeanor but truly may be in need of treatment. And we've had court systems across the state ask us about this over the last couple of years, so we have worked with these court systems to help them set up misdemeanor programs. And you can see which counties have started a misdemeanor program and which ones are in the planning stage that we will then help them set up. And what we've done with these, instead of coming in with the prescribed agenda about how you need to run a misdemeanor program, we have listened to each court that has done this. They have been set up in a number of different ways, and now we're collecting data around each one of the models that exist. There's basically about 3 models that exist around the state, and we're collecting data on those and the outcomes and effect of those, and then we'll be able to start sharing what has worked best, what kind of model seems to have the best outcomes for persons in our state. And right now we have about 1,500 persons that are involved in misdemeanor courts, and we're seeing really good outcomes from these. So I'm going to tell you about a couple of other diversionary things that we do, and then I want to talk to you about what the future looks like. Some of the other things that the Department of Mental Health and Substance Abuse Services does that a lot of people are not aware of, one has to do with reentry. We actually have our staff placed in Mabel Bassett Correctional Facility, in Joseph Harp Correctional Facility, which is in Lexington, and then one here in Oklahoma City, which is a lower level program. And what those people that we place there do is they help develop discharge plans for persons with serious mental illness who are going to be coming to the community, because we want to make sure at that point in time that they are successful when they get to the community. We start that process through video and working with the community. For the discharge planner inside the walls works with someone outside the walls and gets that connection facilitated. And they help them with everything from housing, employment, making sure they don't ever miss their medications, that they get back into treatment immediately when they come out. In addition to that, we have what are called RICKET teams, which are Reentry Intensive Care Coordination teams. We have those in Tulsa and Oklahoma City. And those are teams that wrap themselves around a person with severe mental illness that's been discharged from the criminal justice system, to really make sure for folks that have been quite ill. And oftentimes, I have to say, people discharge from our correctional system still quite ill. And so these teams wrap around them and really try to make sure that their needs are met, that they're getting the services that they need, that they have a successful reentry into the community. Now, we have bits and pieces around the state currently of a crisis continuum of care, but we don't have it statewide. So we have crisis units, which is a short-term kind of treatment program, usually 3 to 5 day stay, where we can kind of get people back on their feet and then they go back out into the community. We added a few years ago what are called urgent cares, which is really a place like you might think of it as an emergency room, but for psychiatric needs, where a person can come 24/7 and receive whatever care they need. Many people can come there and not need to go on to be into a bed, but they can get their meds adjusted. They may start on a medication. They can get therapy. They could have the family involved, develop a safety plan as needed, and be able to continue on with their life. We have mobile crisis for children right now. We don't advertise a number to everyone for mobile crisis right now because what we have focused on is the child welfare system, the juvenile justice system, and the foster care system. Now, those systems use the children's mobile crisis number tremendously. And so we go out into the community with children's mobile crisis. We intervene in that crisis, oftentimes able to de-escalate and handle the situation that way. And if they need linkage to higher levels of care, that's what that mobile crisis does. So now I'm going to tell you a little bit about where we're going to be July 1st of 2022, which is just around the corner. On July 1st, 2022, we will have a nationwide number for psychiatric emergency. Just like we have 911 now, that is supposed to be, when it first started, to be more for criminal types of things. But as you know, over time, 911 has become the number to call for anything. And 911 gets a tremendous amount of calls around psychiatric emergencies. Well, what we hope to do with 988, starting July 1st, is have psychiatric emergencies be the number, for that to be the number that you call when there's a psychiatric emergency happening. We will have a statewide call center for 988. And when you call that number from anywhere in the state, it will go to that call center where you will have licensed behavioral health professionals that will start working immediately when the call comes in. Now, it could be a number of things. It may be someone wanting information about services. That's absolutely fine. That call line will be able to provide that. Or it may be someone who maybe is not necessarily in crisis, but is not feeling great and really just wants to talk to someone. That's fine. It will have a warm line where someone can talk for as long as they want to talk. But it will also have the ability to assess the crisis that is going on and determine what needs to happen next. So oftentimes a crisis can be managed through the telephone and come to a resolution and things be fine. But if that is not the case, then that call center will disperse what are called mobile crisis teams, and this will be anywhere in the state. And those teams then will go out in the state to where that crisis is happening and meet face-to-face with the individual or family or parties where that crisis is happening. And hopefully through that intervention, that person is able to be cared for in the least restrictive manner. A plan is set up, everybody can get on the same page, appointments can be set, and that's all that is needed. But if that's not all that's needed, if the person is willing to voluntarily go to a higher level of care, and that is what's needed, then the mobile crisis team can take them to the higher level of care. So all of these steps so far start as a result of calling 988. The other thing that 988 will have the ability to do is they can schedule right there real time, same day or next day appointments at any point through that continuum. It could be when mobile crisis is out, they can schedule the same day or next day appointment. It can be when they're on the phone and a crisis has been de-escalated, they can schedule same day or next day appointments. Or it can happen with someone who is just looking for resources. Those appointments can be scheduled. So instead of saying, here's the name and the location of a place that you can go to, you'll actually have an appointment in your hand, someone waiting to see you at 9 o'clock tomorrow morning at this location. And also the ability, if the person has the ability at that point in time, to set it up through technology as well if that's what the person needs. So those are all things that we think statewide are pretty major gaps in the state that we think will go a long way in getting people into care and treatment at the level that is needed for them at a much faster point in time. So we're really excited about that. Now, there is another thing that is going into place November 1st, and that is there was a transportation bill that was passed last session that goes into effect November 1st. And what happens with that transportation bill is that when law enforcement come into contact with an individual, but keep in mind what we're hoping to happen starting July 1st is that less and less will law enforcement be coming into contact with persons with mental illness, because we're hoping 988 will be called and we'll go a different route, mobile crisis. But if law enforcement comes in contact, if they need to take that person greater than 30 miles away for evaluation and assessment or treatment, then a transport company will do that transport for law enforcement. And we really like that for a couple of reasons. Number one, law enforcement never started out wanting to be the people that were the mental health people in our society. And it takes them off the road of doing the work that they were hired to do. But secondly, it is much less stigmatizing if you're a person with severe mental illness to have a transport company in an unmarked car that is comfortable and safe to take you where you need to be than to need to be handcuffed and put in the back of a police car, which just further stigmatizes these illnesses, which are diseases like other diseases, and we need to get away from thinking of them in a criminal kind of matter when there's no criminality involved in a situation. So that will start November 1st. So we'll have all of these things tied together. And in addition, we are developing additional urgent cares and crisis units this year as well. That will cross into next year as well, to try to have these in many more locations that are much closer to the individuals who need care around our state. And so I want to thank really our legislature last year, who really understood the importance of putting many of these elements in place and has helped support these elements going into place. So we're very excited. We're working diligently on these things, but we're on a quick timeline. We feel a lot of pressure, not pressure from anyone except for the persons who need this service. We want to get this out there as quickly and as smoothly as possible, and that is our long-term goal.
Thank you very much. Very informative. Love hearing about these. What we're going to take now is take about 5 minutes for questions. And we're going to do this with each speaker today. So if you have a question now, if you'll be recognized by the chair, if you'll get a hand up.
Representative, you're recognized.
Thank you, Mr. Chairman. I just want to make a couple brief comments. When I was here before, 88 through 94, the mental health department had a champion in Senator Ben Brown.
Yes.
And because of his championship of this issue, we were made aware of it. And I hope you have some champions today, because it's a major challenge. Corrections and mental health never have any support group out there that comes and lobbies us for the needs that you represent. And you said a series of questions. Assessment happens when and where?
So assessment can happen many places, and if you'll bear with me, I'd love to tell you a little bit more. One of the things that we did, we piloted with CARES funds a year and a half ago, and that is putting tablets in the vehicles of law enforcement officers, and we did that at kind of a pilot level. But this year we are rolling out where every police car has a tablet in it, that when they push a button, it connects immediately with a licensed behavioral health professional. So one place that assessments can take place is when law enforcement comes across a person. Now, what often happens is law enforcement just hands that tablet to the person they have come across, and oftentimes they can completely divert and diffuse the situation, and they don't need to take them further. But when they do need to take them further, then that assessment has already taken place, and they know exactly where they're going and when, and that is able to be all set up for them. Otherwise, our urgent cares are a great place to take someone for assessment. Any crisis unit is a great place.
Yeah, but who takes them for assessment?
So it would depend. If law enforcement comes across someone and it's less than 30 miles away for an assessment, then law enforcement would take them. If it's further than 30 miles, then the transport company comes and
Okay.
gets them and takes them.
7% go through rehab process are fairly successful. Why is that number so low?
So the 7% that I was telling you was that for folks who go through drug court and mental health courts versus people that are incarcerated, and you want to know why you think it is that so many don't recommit?
Why such a small percent actually goes through there if there's such a great result?
So I'm not sure where the 7% is coming from. I'm sorry.
But you said that in your statement, you said 7% go through the rehab process.
No, what I said was, and I apologize if I wasn't clear in my communication, that if you take the same person and the same crime and they go on to prison, 25% of those people after they leave will become reincarcerated. If you took that same person and they went to a drug court or mental health court, 7% will become involved with the criminal justice system in the future.
Okay,
So I apologize if I was not clear.
That's okay. I live in the area where this happens in my district, and I'm not sure how effective we are in really. My sheriff tells me to tell you do something about mental health. You can't solve our challenge here. Is there a juvenile component?
There are juvenile drug courts, yes. There's not necessarily a juvenile mental health court.
Okay.
And I think that's something that would be some models to look at. Now, there's some other types of courts around juveniles. More likely than not, when a juvenile has any type of acting out behavior, they become involved with OJA or our juvenile justice system. But to prevent them from becoming involved, it would be interesting to look at some models on the mental health side for juveniles.
Does this
Representative Williams, let's just go with one more, and
Okay,
then
then
I'll open it
I'll
up
be
to other
finished.
people, and then I
All
can
right.
come back to you, okay?
No problem. Did the Medicaid expansion that has happened, is that helping people get funding for treatment now, whereas before they didn't?
Yes, is the short answer. So we're not very far into it, but the vast majority of persons, especially with co-occurring issues, addiction issues, didn't qualify for being declared disabled. And in Oklahoma, that was the only way that they would receive Medicaid. So definitely we are seeing more and more persons who are having coverage. And one of the other things that's incredibly important about that is persons with mental health and addiction issues, whether children or adults, have much greater comorbid medical conditions that go along with those, and they weren't able to receive care for that. And so it's very helpful, I think, to be able to get the entire needs of that person treated now.
Representative Harden, you're recognized.
Thank you, Mr. Chairman. Having spent 40 years in law enforcement, 32 here at Oklahoma City and then sheriff in Adair County, are you working on a plan to keep these people on their medication? Having a mother-in-law that has some mental issues, when she's on her medication, you can't even tell the difference. But once she gets off of it, she doesn't think she needs it. So that's my question. I answered several calls here when I was working up here where people were on medication, their medication runs out, they weren't, and I hate to use the word force, but they were not kept on their medication. Are you working on any plan to keep people on that to reduce some of this?
So that's a really good question, and you're going to actually hear more about that as our other presenters talk. What I would say is we have that ability in the state now through civil commitment laws that allow you to civilly commit someone to have to take their medication, which is called assistant outpatient treatment. But it is not as widely used as we would like. And so it really is a component of working with courts and working with judges to explain to them that it is valuable for them to take their time to oversee these types of cases, because in the long run, it's an invaluable service to their community and to the families of persons who have mental illness.
is that basically a court order from a judge or a court for that person to go to a certain doctor on a certain day to make sure that they receive their medications?
In essence, it is. In the assisted outpatient treatment order, it has to state where they're going to get their care. You can state in there what medications they are to take. So it basically is a treatment plan that becomes part of that order. So yes.
Okay.